was just maintained throughout, even at 4 to 5 years of follow-up. And so understandably, based on this, we were very, very focused on getting patients to the cath lab as quickly as possible, and actually being very non-selective in who goes to the cath lab, because we know that routine invasive strategy, if what they're having is an acute coronary syndrome, people benefit from revascularization. But what's the challenge with this? I'm going to zoom up the studies and the titles when they occurred. And so these were published in the late 1990s, early 2000s for the most part. And most of the major studies that were done in the 1990s, or at least conceived in the 1990s. And so I think it's important to understand what the ACS patient really looked like in the 1990s. And outside of it being pretty much my heyday, and I would say the home of the best music and TV shows, the ACS patient looked very different, and largely because of the evolution of cardiac biomarkers. This is a slide I borrowed from Jim Januzzi at Mass General. And I point out to the residents and the fellows all the time that the initial cardiac biomarkers we still use, just not as cardiac biomarkers. And it was really in the 1990s with cardiac troponin that we've seen the shift that we have currently seen in acute coronary syndromes. But all of these trials were really at either an early age of cardiac troponin or didn't even use cardiac troponin in their management and assessment of ACS patients. Interestingly, and a direct correlate to the development of cardiac biomarkers, is the criteria for acute MIs have shifted over time. And I don't know about your all's hospital. We shifted to the high sensitivity troponin probably around now 18 months ago, almost 2 years ago, actually. And that has dramatically changed the types of patients that we end up seeing. So I'm happy to talk about that for those that are interested. But what's important to know is that as our biomarkers have become more sensitive, we've had to redefine acute MI, but we really haven't redefined acute MI care. So this was what was available back in the 1990s. This was a meta-analysis that was published in 2001. And I want to really focus on the right side of this box here. For biomarkers, based on studies done in the 1990s, you can see that cardiac biomarkers were incredibly specific, specificities of 95 to 100%, but very insensitive. So sensitivities that were consistently less than 50%. What we knew, though, even at that time, this is a subgroup of Gusto, is that cardiac troponin in Gusto 2 predicted events. And so those people that have positive cardiac troponins had nearly double the outcome of patients who were biomarker negative in an ACS cohort. And based on FRIS2 data, was that cardiac troponin also predicted who benefited from revascularization. So if you took a look at the subgroups that were biomarker negative, even in FRIS2, which had the biggest effect of revascularization, all of the benefit was seen in people who were biomarker positive at that time. We shift from there to now. So we mentioned how insensitive those biomarkers were. Even the previous generation, the fourth generation troponin T, had sensitivities that approach 90%. Keep in mind, this is just an initial troponin. This isn't even serial troponins. If you take a look at serial troponin data in the high sensitivity world, the negative predictive value of ACS for people who have serially negative troponins is 99.5%. So it's very effective in ruling out those patients, but the cost is specificity. So we went from a very, very specific test, but not very sensitive, to the point that we created a diagnosis called unstable angina to help identify those patients, to a very sensitive test that isn't very specific. And so for the last 10 years or so, people have been calling for a reclassification or a re-understanding. This was a paper, an editorial that was written by Eugene Braunwald, wondering whether we need to get rid of the diagnosis of unstable angina. And I tell the house staff right now that in the era of high sensitivity troponin, the use of the term unstable angina should be very infrequent. It was a diagnosis that only existed because we didn't have a sensitive enough test. And now we have a test that's so sensitive that if you sneeze in the ED, A, they're going to check troponins, and B, they're likely to be positive. And everything we understood about the medical therapy of acute coronary syndrome has largely been based on a specific pathophysiology and has really only been shown to be effective in these patient populations that are biomarker positive. So that's fine for the assessment of ACS, but what has it done to the actual makeup of our acute chest pain patients? And so this is probably where we were in the 90s. Pretty much everybody that came in the acute chest pain predominantly were unstable angina. And if you take a look at some of the older studies, almost 50 to 60% of patients who were enrolled in trials were biomarker negative patients. And if you ruled them out, then you worried about non-cardiac chest pain. And I would say now it's much more complicated than that. So acute coronary syndromes is still what we worry about the most. Predominantly, though, they are non-STEMIs or STEMIs, but unstable angina represents a much smaller cohort of these patients. Some stable ischemic heart disease patients actually shift in. There was a nice paper from JACC Interventions that looked at intravascular imaging of patients who had acute coronary syndromes and showed that almost 50%, a little bit less than of the ACS patients, never had a disrupted plaque. We have this whole nother category, which we'll spend a little bit of time talking about today in Minoka, and then probably the bane of every consulting cardiologist, the non-ACS troponin elevation. We're not sure why we got a troponin, but it is now positive. And so this makes it a little bit more challenging to assess, but it also impacts what we see and find when we take people to the cath lab. And so if you take a look at FRISC-2 data, about 70% of the people that went to the cath lab got revascularized. And the most recent non-STEMI trial, which was the VERDICT trial, and VERDICT really looked at timing of revascularization in non-STEMI, that rate of revascularization dropped to 56%. And actually, when we took a look at our data across 10 years, it was closer to 50%. It didn't even hit 50%. And with the most recent iteration of troponin, it was actually in the 20% range. And so this redefinition of acute MI and the increasing sensitivity of troponins has really flipped the script a little bit on what happens to these patients. This is sort of borne out in the literature. This was the NSTX trial. And what they did is they took a look at patients diagnosed with high sensitivity assays and who were diagnosed as an acute coronary syndrome by the third or fourth universal definition, depending on when they were enrolled. And they actually took all of these people to coronary CT and then the cath lab. Now, I'm not really focused on the coronary CT aspect of it, but one of the things I wanted to point out here is in this cohort of acute coronary syndromes, by strict definition, about a third of all the ACS patients had non-obstructive coronary artery disease. So we thought clinically they presented with, in the NSTX study, there were only chest pain patients that were included, but we included chest pain patients, positive troponin, significant delta, sort of a strict definition for an acute coronary syndrome, and still about a third of those patients had non-obstructive disease, creating this whole nother diagnosis called MINOCA, myocardial infarctions with non-obstructive or normal coronary arteries. Interestingly, there has been some work done on this, and I'll share with you the breakdown of this, but the three most common reasons why people have a MINOCA is a stress cardiomyopathy, myocarditis, or interestingly, despite a normal or non-obstructive cath, an acute MI. And so how did we figure that out? Most of the studies use CMR. Judith Hockman and Harmony Reynolds did some work with IVUS imaging too that correlated with this. But CMR is very effective in MINOCA patients. And so patients who come in with very concerning stories, very convincing stories, positive troponin, significant deltas, but we take them to the cath lab and their coronaries do not show any obstructive lesions. Either intravascular imaging or cardiac MRI is extremely helpful to know what happens with these patients. It's diagnostic in 75 to 80% of the cases. But what was really insightful about this is the number of those patients that ended up being diagnosed as having a coronary event by CMR. So they had late gadolinium enhancement and a coronary distribution, or edema and a coronary distribution, occurred in about a third of the Minoka patients that came up with the diagnosis and about a quarter of the overall cohort. Interestingly, when we looked at IVUS or OCT data, and again, this was work that Judith Hochman did, that number may be as high as 40% of patients who had no luminal obstruction or mild luminal obstruction. When you actually took a look at the plaque, you actually saw disrupted plaque, suggesting that there's probably a significant proportion of these patients that got recanalized, either because they were on medical therapy or their intrinsic fibrinolytic system that allowed for restoration of blood flow. And I will tell you, in some of my partners, we see a lot of variance in terms of who will revascularize those patients. I can appreciate not feeling compelled to revascularize those patients, but I will say that medical management and the subsequent downstream care of that patient should probably be more reflective of ACS than myocarditis or stress cardiomyopathy. So dual antiplatelet therapy, high potency statin, and then some of the other things we're going to talk about in terms of cardiac rehab. So that's largely been our focus, and I would say the shift in acute MI care, but I wanted to spend a little bit of time talking through some of these other aspects. Before I do that, did anybody have any questions about some of the data we just talked about in terms of revascularization? So let's talk about antiplatelets and anticoagulants first. One of the challenges with looking at antiplatelets and anticoagulant strategies is that they really overlap in time with invasive versus conservative strategy, so it makes it a little bit more difficult. When we talk about triple antithrombotic therapy, so dual antiplatelet therapy plus anticoagulation upstream, they were all in the sort of setting of an invasive strategy outside of cure. So it does complicate things, but I do think there's some things we can learn from these studies as they occurred. The guidelines, and this is the most recent ESC guidelines, I think the ESC guidelines have nicer graphs to display this, have really emphasized the role of bleeding risk and ischemic risk. Most of them still favor upfront loading with anticoagulants and upfront loading with antiplatelet agents, or at least loading in the cath lab with prasugrel if we are going to do an intervention, but then reassessing what their bleeding risk is and comparing that to an ischemic risk. So this is patients who do not have atrial fibrillation or another indication for systemic anticoagulation. It's really emphasizing patients who had higher bleeding risk to either switch to a lower potency P2Y12, like clopidogrel, for a shorter duration of time as possible. And I think that we're still a little farther away, I would say, in the US, even with STOP-DAPT and Twilight and other studies that have really talked about shorter duration antiplatelet agents. I usually don't go 3 months, but I will go 6 months pretty comfortably now and stop dual antiplatelet therapy or shift to a single antiplatelet therapy at that stage. What's more interesting is the shift in patients who need systemic anticoagulation for whatever indication, most commonly atrial fibrillation. So with the WOSH trial, and what we did initially is we actually went to really 1 month of triple therapy and then stopping the aspirin, continuing people on just a single antiplatelet, a P2Y12 inhibitor, and then a NOAC or DOAC. I will say that after Augustus, I don't even do that. I don't discharge anybody from the hospital now with triple therapy unless they have an exceedingly low bleeding risk and they've proven failure with a single antiplatelet anticoagulant strategy. It has substantially reduced our bleeding complication rates as we've tiered back our triple therapy use in our hospital. I will say with DOACs and a single antiplatelet, I've generally been able to get most people to 12 months. Very rarely will I do a 6-month course But I feel comfortable doing a 6-month course and then continuing on a DOAC alone. Usually I do that for patients who have a procedure upcoming or have some bleeding complication associated with it. And again, even in those that have a high ischemic risk, unless they have proven failure, in-stent thrombosis with or recurrent ischemic events with a single antiplatelet and a DOAC, they usually avoid triple therapy in most of these patients at this time. We're going to talk a little bit more about upstream use of anticoagulants when we talk about, strategies to improve care and minimize readmissions here in a second. But I wanted to transition to sort of the role. And again, these are things that I think we're all fairly comfortable with in the literature. This is the Prove It study that looked at high intensity versus moderate intensity statin therapy after acute coronary syndrome and showed a reduction in major adverse cardiovascular events and death as a cumulative outpoint. It was predominantly a reduction in ischemic events, although there was a non-statistically significant reduction in mortality as well. And then something that I'm very passionate about, and it sounds like a really robust cardiac rehab program at your all's facility as well. So hopefully you've appreciated the benefit of it. I actually just ran into our cardiac rehab director about this, and they're working really hard at getting in-home cardiac rehab as well to hopefully reach more patients as a result of this. But as you all know, it's so much more than just exercise. And I'll share some of the data that exists for this, but we have pharmacy support, discussions on smoking cessation. It allows people to be more active with safe resumption of activity and really lifestyle modifications and how to make them sustainable. The impact of cardiac rehab has been shown in multiple different studies. This was one of the larger studies that looked at approximately 2,000 patients. And when they just did a head-to-head comparison of cardiac rehab versus no cardiac rehab, they saw a reduction in cardiac mortality, all-cause mortality, and ischemic events as well. One of the criticisms of most cardiac rehab studies is that it is retrospective, and that is fair. But even when they've done matched pairs comparisons, so looking at people based on frailty, activity level, LV function, and controlling for all of those things, you can still see a significant reduction in all-cause mortality. This was seen in another study, a more recent study, and you can see here that time to death, so mortality rates were nearly half if you did cardiac rehab as opposed to if you did not. And this was sustained benefits seen over the years. You can see those curves separate out. And the group that probably saw the most benefit in this were the ACS patients. So the non-STEMI patients. We talked about a relative risk reduction. Take a look at all of the studies of about 26%, an absolute risk reduction. It's on the order of 1 to 2% in a 1-year cohort. You're seeing higher mortality benefit from cardiac rehab. This is really only, I would say, the tip of the iceberg with this. It is also an essential aspect for functional improvement in patients, and then a reduction in heart failure symptoms and readmissions from that. And I'll show that data here in a second. So that was a quick review sort of the literature as it currently exists. Questions people have, things that I didn't go over that we want to go over before we sort of transition into how do we make that a part of our practice as a matter of routine course. All right. So let's talk some about the major cause of rehospitalization. Again, I think this will sort of lead into what we do and what are some strategies we have for improving sort of standard systems of care. Because again, as busy providers, if everything that can be done by someone else is being done by us, it does limit our ability to focus on the things that only we can do in the care of our patients. So this was a really nice study from the Get With the Guideline Networks. Greg Fonarow and his group did this. And really what was nice about this is they split this up into two sections. One was, so the acute processes, these are the things we all focus on. And I will tell you, when I'm in the CCU or when I'm on ED consults, this is a priority of mine, is making sure people are loaded with the right medicines and get them to the cath lab as quickly as possible. And actually, we have been in the process of doing an update of our care redesign for acute MI, and that was one of the things that we identified was an area we wanted to get better at, was end-STEMI care, getting in the cath lab expeditiously. Interestingly, those are things that aren't very different between people that get readmitted, but there are strategies within this initial management that I think we can focus on, largely bleeding reduction strategies. And probably the most important one is access. And so this was the matrix study. There have been a bunch of studies that have been done since then. On this graph, the blue line is radial access. The red line or orange line, I can't tell what color it comes across as, is femoral access. This is taking a look at sort of a composite vascular endpoint, all-cause mortality, MI, or stroke. This is STEMI and this is non-STEMI up here. And you can see that just radial access reduces major adverse cardiovascular events, especially in the non-STEMI cohort. And if you start including a bleeding component to this, then it actually benefits in STEMI and non-STEMI. Just to prove that a little bit further, I appreciate that this is a busy slide. I want you to focus just on this line right here. And so you can see in STEMI patients, you can reduce bleeding complications, and this is sort of across the board bleeding complications, by 40 to 50% in relative terms, and in absolute terms, about 6% to 8% absolute risk reduction. To give you an idea, that means you can, if you, from 10 to 20 patients in the STEMI cohort, can reduce one bleeding event if we switch to radial access. There was not an increased risk if you take a look here in stent thrombosis. In the more recent studies, there is not a reduction in ability to complete the revascularization. Some of the older studies, that was a concern, but as people have gotten more comfortable with radial access, as the catheters have become more accessible with radial access, it's become a much more consistent modality. And then the other thing that I think is an important one to revisit, and we just haven't, and to be fair, the guidelines haven't, but this is a conversation that we have on a regular basis right now, and probably an important one to have in people that are high risk of bleeding, or especially if we're choosing to go femoral access so we can reduce our bleeding risk, is what is our upstream antithrombotic strategy? So this was a meta-analysis that was published in 2010, I believe. And this actually looked at the different antithrombotic strategies. So a single antithrombotic agent, aspirin versus placebo or heparin versus placebo. And you can see a distinct benefit in MACE rates. But again, now everybody gets aspirin. Now we're debating between aspirin plus P2Y12 plus heparin versus aspirin and heparin. And you can see the more antithrombotic agents you add on, the less the benefit from an ischemic standpoint and the more the risk with bleeding. So one of the things that we are really pushing is, especially during the day for our non-STEMI patients, once we've made a diagnosis, we work really hard to get them to the cath lab, and we actually don't worry about upfront loading with heparin. We will put them on an aspirin and a P2Y12 inhibitor and get them to the cath lab. They will get a bolus of heparin in the lab because we do over 70% of our cases with radial access, even our ACS cases. And so it is really something that we try to get them to expeditiously to revascularization instead of trying to keep them overnight, heparinize them, put them on Lovenox, keep them therapeutic, maybe get super therapeutic, and then go to the cath lab. Really just try our best to get them expeditiously to the cath lab. But this may be something, especially if they have high bleeding risk otherwise, or if we're concerned that we're going to have to use a higher bleeding risk strategy like femoral access to maybe minimize the amount of upstream heparin use in those patients. until we can see their anatomy and see what we need to do from a revascularization standpoint. This second part, I think, is part of the area where we and us included as cardiologists have just not focused as heavily on, and probably makes a bigger impact in terms of revascularization is what is our downstream care for our patients? So this was a really nice study that looked at specific causes of 30-day readmission. I can see that that's tough to see. And so just zooming this up, if you take a look at some of the most common indications from cardiovascular causes, it's really recurrent angina or anginal type chest pain, or other non-cardiac chest pain associated with immobility. And so what are the things that we know help reduce events? Again, if you look at Prove It, the downstream benefit of a high potency statin was largely to reduce recurrent revascularization. So it not only helps in terms of your initial management, but actually probably more helpful downstream to reduce some of those ischemic symptoms. And then cardiac rehab participation cuts hospitalization rates in half, more than half, in at least this study. And again, you take a look at which cohorts benefited the most from this rehospitalization risk reduction, it was NSTEMI patients. And so for our ACS patients, I think there is definitely a distinct benefit in getting patients consistently high potency statin and then getting them consistently to cardiac rehab as best as we can. One of the other things I like to point out on this, I didn't point this out, but bleeding complications is one of the other ones. So all of the things we talked about in terms of a bleeding reduction strategy, it really just does translate into recurrent rehospitalization rates for patients. So I'm going to take the last 10, 12 minutes of time, and then I want to really, save some time at the end specifically so we can talk through some of these things. And I understand you're all making the transition to Epic at the same time we're making this transition to Epic. And so I'm happy to help, facilitate conversations around what we're doing to help with this, and strategies that we're incorporating into our Epic transition that I think will help us with this. I've lived in Epic before, and so also happy to help talk through that for individuals if they're curious or interested. So one of the challenges, and I think this is all appreciated, is really an implementation problem, right? I mean, we all know, and on a very, very individualized level, I think we're all committed to delivering the best care that we can. But we collectively as a field have underutilized most of these tools. And I will tell you, as someone who's very involved in value-based care, this is going to be our task in the world of value-based care as we make that shift from volume, is how we tighten up the total spectrum of care delivery. This is going to be absolutely essential. And as physicians, I would say that, and I'm guilty of this as much as anybody, is that we are geared to do everything that we can for our patients on an individual level. And I would say that in this case, ceding some control is going to be essential. The more we can leverage team members who have expertise within this to standardize care that we know works, the better off we're going to be. And this has been recognized across the country. The Million Hearts program is an initiative from AHA and CDC, really trying to get cardiac rehabilitation rates up to 70%. Right now, the true rehab admission rates is around 20 to 30% when this program was started, of all people who would be eligible. But this is really a change management question. And these are some strategies that we use and that we've done care redesign in a few different areas within cardiology, of really just making sure that it's as effective as possible. There is nothing more off-putting as a physician than to be told I should do X, try to do X, and feel like you're delivering substandard care as a result of it. It turns all of us off to other care redesign efforts. But I think when providers drive change, it is the most effective. And one of the things that I do before we ever incorporate and talk about how we're going to implement this is I make sure that we talk about it at faculty meetings to make sure that we're all on board with the change that we're trying to make. Because if we can all get on board with the notion that, listen, this is the best care that we can deliver, then the how becomes a little bit more palatable. I think when there's a disagreement up front about what we should do, it's when the care redesign doesn't take. So one of the things that I really emphasize is that providers should be the ones helping to dictate what the process ought to be, what the care redesign ought to be, and then a commitment to stick to it for a fixed period of time before revisiting it. So we're going to come back at 3 months and revisit the data and see if we need to modify this. Instead of doing it on a point-by-point basis, that can be a little bit challenging to then see the effect of the care. I think it's really essential to empower team members to drive this change. Our pharmacy team has owned this and run with it. Caitlin King is our inpatient rehab coordinator, cardiac rehab coordinator. Some of you may know Caitlin. Caitlin is phenomenal. And so as soon as she hears that we may have someone, she takes the ownership to move it forward. And as we've started with making the transition to Epic, one of the things we did was facilitate pharmacy, engage pharmacy and cardiac rehab on how can we do this better. And then one of the things that Tammy and I were talking about earlier is that really the key to all of this is make the care redesign process the path of least resistance. It should be the easiest thing to do. So I'm going to share with you our CATS Pledge program. Again, this is just one solution to it, but it has been incredibly effective for us. And so like with most cardiology initiatives, the name is just as important as the actual initiative. And so I'm sure Tracy McCauley, our pharmacist that helped put this together, is probably the one that came up with this. But really what we have said is that all PCI patients are going to be enrolled in CATS Pledge, regardless of how complicated they were, regardless of the specific nuances. Everybody's involved in this process. And it's a multidisciplinary, multi-step process, but it was largely driven by our pharmacy team. But there's rules for everybody. And what it freed us up to do as physicians was the diagnosis and the initial management. Our interventional team could focus on the PCI, spend their time and effort thinking about how they were going to do it, what subsequent revascularizations needed to happen. For me in the intensive care unit, I could focus on the medical management of if they came in with cardiogenic shock or low output heart failure, how do we navigate through this? And then our pharmacy team really worked with us, and the inpatient pharmacist started this process. They did a very, very extensive discharge medication discussion with them, and then they did a handoff to the outpatient pharmacist that saw all of those patients within 7 days. We have the pharmacy clinic at the same time as a provider clinic, and so on the rare occasion that the pharmacist does need some help, then we have a provider on site that can help triage either acute issues or help to make some clinical decision that's beyond just medication itself. We have a role of our nursing staff within this, as well as our front desk staff. And then we have managed to negotiate to get our core medicines for free at the time of discharge. But this process or this system is relatively independent of that. I think it is essential, though, that patients physically get their meds whenever possible before they leave the hospital or leave the premises. And so whether that's working in arrangement with the outpatient pharmacy, which is how we started this, with something called meds to beds, but it really worked with their insurance to get them 30 days physically in hand of their medication so they don't have to stop anywhere, and remove one of the barriers to medication compliance. And so as a stepwise process, there's a lot that we do on the front end, but there's really an enhanced discharge process. The inpatient pharmacy team does this. We have pharmacy residents that spend a fair amount of time doing this, and then they do what they call a warm handoff, pharmacist to pharmacist. Um, like I said, there's a physician that's on site. I do our ICU recovery clinic, and so that's one of the CATS Pledge days. So I'm one of the providers that helps to serve as backup for the CATS Pledge program. There's a phone call within 48 hours, and then there's a follow-up appointment within 7 days. And so, literally, what gets handed to me as the attending cardiologist, and actually now even the fellows just take care of it, is this form that's already pre-checked, and this serves as the prescriptions for it. So the pharmacist, based on what the patient is on in the during the hospitalization and based on a conversation during rounds, if they have questions about this, they directly ask me, so and so doesn't have insurance moving forward for ticagrelor. Do we want to transition them to clopidogrel? Um, let's do that right now. And then they literally will check this off. The medications that we think are the most appropriate always get moved up to the top of the list. So, like human nature, the checklist part of it, it becomes a little bit easier. And then we know if we are discharging someone on a high potency statin, we're going to see them in 7 days. So we can make the assessment about whether their LFTs are okay, if we were concerned about that, or if myopathy has been a concern. We also use that as an opportunity to order recheck on labs. And so it has happened a few times where we initiate therapy for ACE inhibitors and or spironolactone, and we know when we're going to want a recheck. We know we're going to have a touch point in 7 days to get that creatinine recheck, to get that potassium recheck as well. So I literally get this, we sign it, and it's done. So as I mentioned, to make it the path of least resistance, there's no question about who's going into it. And this is sort of just a part of the natural daily huddle that we have with our team. And because it is a default order and a follow-up, we actually don't even worry about the initial follow-up. The schedulers know that schedule is going to be made in 7 days in this CATS Pledge appointment. And we can then focus back here on what their subsequent follow-up ought to be. And so this is one where we talk to the patient, where, what's closer to home for you? Would you like to follow up with one of our partners that are in Elizabethtown or Frankfurt or in Georgetown, wherever it may be, because we appreciate that proximity is important, and we just want to make sure that they follow up wherever they feel like they can get their continuity of care, because we can really focus on the transitions of care in that initial CATS Pledge appointment. So that's just one of the things that we've done, but there's a lot of literature that's out there. This is one of my favorite little short reviews on this. This is actually a series of 4 review articles that talks about sort of optimizing care delivery for those that are interested. Brian Gibbler is actually an emergency medicine physician. Was the chair of emergency medicine at Cincinnati when I was a medical student there. And he is also very accessible. He was involved in all the initial Gusto and TIMI trials when they existed. But with that, really wanted to thank you all for taking the time to talk with me and invite me out here. I've saved a little bit of time at the end just to make sure that we talk about it. And really, I think one of the most important take-home points for this is really identification of etiology, getting people to revascularization quickly, but then not forgetting about the other aspect of care delivery. So our job's not done when the angiogram is done. We may have some more diagnostic work to do. We really want to emphasize bleeding reduction strategies, getting patients to sort of optimal medical therapy and for cardiac rehab. And whatever we can do to standardize that work so that it's the easiest thing to do. Make the right thing the easiest thing to do. It's much more likely to get done. And with that, if you have questions, feel free to reach out to me. I'm always available. If there are, questions specifically, I'm an advanced imaging cardiologist. I emphasize the role of cardiac MR, but I appreciate it can always be challenging to get people in. If there's things I can do to help facilitate that process, always feel free to reach out to me at that point. And if there's opportunities to collaborate, whether it's with the epic transition or otherwise. Like I said, I think we're better when we do this all together and help deliver better care for everybody here in the Commonwealth. So with that, Tammy, I'm going to send it back over to you. If there are questions that people have, like I said, I'm happy to stick around and help try to answer them or talk through them or share stories, insights, thoughts.
Well, thank you, Dr. Gupta. We really do appreciate you spending the time with us tonight. Again, if you would like CMEs or CEs, just email me, tramsey@hmh.net. And if you have any questions for Dr. Gupta, please feel free to stay on the line or send them to me, and I will get those questions to him, either one. And with that, I turn it over if anyone's got any questions. If not, I appreciate everybody being on tonight, and we thank you all. Always feel free to reach out to me for any kind of your educational needs, and the same, I'm sure, with Dr. Gupta. Thank you all.
Yeah. Thanks, everyone. Stay safe.